So the main trend we're seeing these days is a very large increase in the interventional oncology patient volumes. I think patients are looking for minimally invasive treatments that will replace open surgical techniques. And as a result, we've had to adjust to that increase in the liver oncology volumes. In addition to that, we're also just seeing an overall increase in the number of patients coming through our department, in which case we're looking for ways to improve our efficiency in the department as well as streamline the process. And the GE machines have been very instrumental in being able to do that.
In my opinion, the future of interventional oncology is more and more advanced 3D imaging and more precise treatments. This equipment has helped me in that respect, in the sense that I've been able to acquire cone beam CT much more easily during cases because of the wide bore of the gantry. And then the reconstruction software has been very helpful in that it's very intuitive and saves time off of my cases. It also allows me to treat cancers much more aggressively and safely at the same time. With this equipment, I'm able to combine procedures on the same day and do chemoembolizations and microwave ablation on the same patient at the same time. That allows me not just to save time as well as radiation exposure to the patient, but it allows me to treat more tumors that are in much more difficult locations than I was able to treat in the past with CT. So this has expanded my practice and allowed me to treat more patients. And so it helps me do multiple procedures at the same time and to do those procedures better.
We routinely used to do all of our ablations in our CT scanner. And there were patients that we couldn't ablate their tumors because of the idea that they were high up under the diaphragm, or they're in locations that I cannot get to with a conventional CT machine.
The advantage that I've discovered with cone beam CT is that with the needle assist software, you're able to find a trajectory path basically in any obliquity and then place that needle under live fluoroscopic guidance in one step. And so rather than multiple different CT fluoro acquisitions, you're able to place that probe immediately and get it exactly where you want it. Repeat the cone beam CT and confirm suitable positioning and move on with your ablation.
With this rotational 3D CT software and the trajectory planning, I can get my needle at any complex angle, which essentially has allowed me to treat a much higher number of patients that I previously would have not been able to offer treatments to.
Most cone beam systems that I've used have needle assist type software. The problem with a lot of those systems that I've used is that there's not enough room under the gantry once I've acquired the image and have applied the 3D overlay to actually get under the gantry to then place the needle comfortably. With this system, because the gantry is so much larger and there's so much more room underneath it, I found that there's almost never a situation where I'm limited in using the needle assist software just by virtue of being able to get under the equipment.
When I was performing high-end procedures in other labs that we've used, the difficulty I had with rotational CT was a real constraint, in the sense that patients often had to be moved on the table, their arms raised up, in order to do these spins and make the machine complete the rotation around the patient.
The requirement of getting a patient's arms above their head just to acquire a cone beam CT can be a major limitation. With the GE Discovery, I'm able to acquire cone beam images on almost every patient of almost any size with their arms down, with no repositioning. And so that allows me to use that technology as a fluid part of my procedural flow without having to disrupt everything.
The spin capabilities of this machine allow me to do rotational 3D CTs and confirm my wire position before I start ballooning and doing all sorts of complex stenting of these venous systems. That was not feasible in the other systems we have because of the idea that patients' arms need to be above their head. If I'm working from the arms with some of my access, then I cannot spin that patient. With the GE machines, the arms come to the side, the machine spins around, I can get high quality rotational 3D CT images. So from a venous recanalization perspective, it's been massive to use this machine.
In the past, when we would do a case with general anesthesia and would try to acquire a cone beam CT image, oftentimes the anesthesia equipment would be in the way. we would have to temporarily disconnect the patient from their respirator just to acquire the cone beam CT image.
With the GE machine, the machine spins without having to detach anything. That certainly makes the anesthesiologist's job better, which makes the whole procedure run more efficiently. So a good example that I would use is a TIPS, for instance. I would never have done a TIPS procedure with rotational 3D CT in the past with other machines because of the reasons I suggested, right? The inability to create a spin while I'm working at the head of the table and the anesthesiologist is having to detach all their lines to do the spins. Now with the GE machine, I stand at the head, we basically get ready to do the spin, I step out, we can do the spin. And the reason that's helpful is because oftentimes I don't know whether I've accessed the portal vein safely. The spin shows me the exact location of where that access is, and I can then complete the procedure safely. That's all possible with a GE machine that was not possible with other machines that we'd used. Many of the other systems, the table is required to break so that you can image the arm. That's probably been one of my favorite features of the GE Discovery machine is the ability of the gantry to move independently of the patient entirely. So I don't ever break the table. The GE machine can really just slide down the arm, you can image the arm, and then you slide it right back into the position that you like. The in-room console that allows you to measure stenoses. So for instance, if I'm doing an arterial case or an endovascular venous case, and I need to know the length of my occlusion as well as the diameter of the vessel, other machines, I would have to walk out of the room, break scrub, I would have to sit down and do those calculations at the external workstation. On the GE machine, it's 3 clicks, I can measure on the screen, and all of a sudden I know what my stenosis length is as well as the diameter. And then finally, if we're doing rotational 3D CT, we have the in-room mouse that we're able to use, so once again, I do not have to scrub out and take gloves off and sit down at the station. I can do it all within the room.
One way that the GE Discovery has really opened up my practice is it has allowed me to treat lesions which in the past I would not have been able to treat with the systems that I had. For example, there's a patient that I've been treating now for several years that has metastatic colon cancer. He's had multiple different treatments to his liver in the past. He's had surgical resections, he's had radiation to his liver, I've done transarterial embolizations to his liver. And at this point, we basically follow him on a regular basis to see if any new tumors develop. Unfortunately, recently, he came back to my clinic and had developed 4 small tumors. And these tumors I could see on advanced imaging like MRI, but unfortunately, to treat very small tumors like that, it's very difficult to treat them with any techniques that we have because they're too small to see with CT or ultrasound. And if I can't see them, I can't treat them. So after talking to the patient, I explained that our options were either to wait until they get larger so I can see them, or to attempt to treat them with the GE Discovery using some techniques that we've created through our use with this equipment. So basically what we decided to do for this patient was to treat him with a combined embolization microwave ablation approach. My thought process was if I did a transarterial embolization, I could acquire cone beam imaging with arterial contrast rather than venous phase contrast that would allow me hopefully to see these small tumors on cone beam CT. If I'm able to see them on cone beam CT, I can then use the software that the system has to mark these tumors so I can see them with real-time fluoroscopy. And then once they're marked with real-time fluoroscopy, then I'll be able to advance an ablation probe into them safely and to be able to treat them. He came in for the procedure, we did the arteriogram first, and fortunately I was able to see them with the cone beam CT imaging. I then marked them with our computer software, and I could see them with real-time fluoroscopy and then very easily was able to place the ablation probes into all 4 tumors. We then treated them. He went home the next day, and on his follow-up now, he's approximately 3 months out from that procedure. All tumors were successfully treated with no complications. 2 years ago, if this patient had shown up, I really don't know if I would have been able to offer him any treatment. I could have treated him with transarterial therapy again, but the problem is with tumors that are that small, they usually don't have a significant blood supply. And so any treatment that I provide from a transarterial route is potentially likely to do more damage to the normal liver than to actually treat the tumor. I probably wouldn't have been able to treat him with ablation because I wouldn't have been able to see these tumors with either ultrasound or non-contrast CT, which is typically used for ablation. So had this been 2 years ago, I would have just had to wait until the tumors got larger. And this is an example of how this has changed my practice.